morning, good afternoon, and good evening. And thank you everybody for joining this event titled Reaching Herd Immunity Behaviorally, Supporting COVID-19 Vaccine Take-Up with Social Media and Beyond. My name is Carolina Sanchez-Paramo, and I am the Global Director for Poverty and Equity at the World Bank. And it's a real pleasure to have the opportunity to chair today's event. Very much looking forward to the discussion with our panelists, as well as with those of you who are participating. Today's event is part of a series on the topic of vaccine hesitancy and access. And I hope that many of you were able to join another event within this series that we had last week that focused on these issues, particularly in the Africa region. As you know, as vaccines become more available, including in developing countries, we hope over the next few months, addressing demand side constraints will be critical to bring an end to this pandemic. To do this, we need information on how individuals feel and think about vaccines. You know, what are some of the constraints or the hesitancy that they feel at the moment, so that we can use communication campaigns and design rollout efforts in ways that they combat and effectively address hesitancy and other constraints. And that's really going to be the focus of today's event. How can we measure hesitancy? How can we have a better understanding for what it means and what causes it, so that we can really think about how to actually address it. This event would not be possible without a very close collaboration between the Poverty and Equity Practice on the one hand, and the Development Impact Unit, as well as the Health, Nutrition, and Population teams within the bank. And I also want to acknowledge the support that we have from both Merck and Facebook for this effort. So it's truly teamwork that we are seeing here today. And also, I want to welcome anybody that may be joining us as part of their participation in the UN Behavioral Science Week. If you're one of those people, welcome, and it's really great to have you here. So we have a lot packed in the next hour and a half. So let me give you a quick sort of roadmap of how this is going to work. We are fortunate to have David Wilson, who's the Program Director in the Health, Nutrition, and Population Global Practice. And he's also at the moment the team leader for the COVID-19 Fast Track Facility and the Health Emergency Preparedness and Response Fund. So David has been really at the forefront of the bank's efforts to support countries in responding to COVID. He's going to provide some opening remarks at this event. Welcome, David. It's great to have you here. And then after that, we'll move to a set of 3 presentations by some of our panelists, who I will introduce after we hear from David, and then we'll have an open Q&A and debate with them. So as you can see, a very rich agenda moving forward, and looking forward to it. So without further ado, David, the floor is yours, and welcome everybody again.
Thank you very much indeed. We heard last week how remarkably effective these vaccines are. If we had thought a year ago that our first 2 vaccines would be 95% effective and completely safe, few of us would have believed it. Similarly, if we had thought last year that we would have not 1, but 6 WHO-approved vaccines before the middle of the year, few people would have believed it. So the good news is we have extraordinarily safe and effective vaccines. The additional good news, as Carolina has said, is we are starting to see vaccine supplies increase. Until now, it's true that vaccines have been almost entirely in rich OECD countries, but we are starting to see an increasing number of developing countries obtain and use more vaccines. And COVAX will supply a growing number of vaccines in the second half of 2021. And in addition, the African Union Vaccine Acquisition Task Force, supported by the World Bank, have secured 220 million doses of Johnson & Johnson for Africa. So we now have not only the promise of effective vaccines, but increasingly the reality of their availability. this is where we now face some important challenges, and this is where today's session is so important. We have safe and effective vaccines, but these COVID vaccines are only approved with a 6-month shelf life, unlike almost all other vaccines, which have a 3-year shelf life. So we have to use these vaccines with unprecedented speed. And we have to do so in a context of hesitancy and in a context of misinformation. And those of us with family in many developing countries, including Africa, will be well aware how much social media contributes to the flow of inaccurate information. And that's one of the many reasons why today's session is so appropriate. Not only do we need to counter misinformation, but we need to apply all of the potential and capacity of social media and all of the strengths of our behavioral insights teams during this, the UN's Behavioral Week. And that's why I'm so pleased to introduce this panel that will focus on social media and the role of behavioral insights in overcoming hesitancy. Thank you, Carolina.
Thank you, David, for joining us and setting up the stage so nicely. So we are moving now to the sort of presentation / panel discussion section of the session. So I'm going to brief the panelists, and then I'll pass the floor to them for some short presentations. So we are really privileged to have with us Lisa Menning, who's the team lead for demand and behavioral sciences in the Department of Immunization, Vaccines, and Biologicals at the World Health Organization in Geneva. Welcome, Lisa. We also have with us Dr. Neetu Abad, who's a senior behavioral scientist in the Global Immunization Division and the co-lead of the Vaccine Confidence Team in CDC's Vaccine Task Force. Welcome, Neetu. Thank you for joining us. We also have with us Siv Malu-Nielsen, who's a technical officer for vaccine acceptance and demand at the Vaccine Preventable Diseases and Immunization Unit, again in the World Health Organization, and she's part of the regional office in Europe. And then finally, we have Renos Bakis, who's a lead economist in the Poverty and Equity Global Practice, and also in the Mind, Behavior, and Development Unit within the practice. So welcome to the 4 of you. We are really looking forward to this part of the session. We're going to have, as I said, 3 short presentations on different topics that hopefully will set us up very well for the discussion. We'll start with Lisa, who will speak about the drivers of vaccination uptake and diagnostic tools. After that, we'll hear from Neetu on US efforts regarding vaccine confidence and demand. And then we'll hear from Renos on lessons learned from some of the social media work that we are conducting here at the bank. They'll each speak for about 15 minutes, and then we'll have a question and answer session. So Lisa, the floor is yours.
Thank you very much, Carolina, and thank you very much to the World Bank and colleagues for the collaboration. So in this short presentation, just to endeavour to set the scene, we'll be talking about the drivers of vaccination uptake, looking at it quite holistically, and how that translates into various WHO recommendations for implementation of the range of strategies to support uptake, and we'll touch on some of that available guidance as well. So I'm just going to start by just moving to the next slide. So just start by recapping on these drivers of vaccinations. So we consider these to be the behavioural and social drivers. And this is a framework that was developed by an expert group over the last 3 years that WHO has worked with. We initially set out to do this for childhood vaccination, in fact, and then adapted it and extended it for COVID vaccines last year. And it essentially indicates these 4 main domains that contribute to uptake, what people think and feel. And this is where we situate confidence and attitudes and perceived risk, as well as exposure to negative information, misinformation, myths, etc. And then there's also social processes, social influences, norms at various levels in the family, community, workplace, as that's also applicable for COVID vaccines for health workers. And typically these 2 domains then contribute to shaping motivations. And for the motivations, this is where we situate hesitancy. It's a motivational state. But here we also capture these intentions or willingness to get vaccinated. And then lastly, but not least, these practical issues that contribute to shaping what happens when people are motivated and their ability to carry through with those behaviours, essentially. So within the practical issues domain, this is where we include the ease and convenience of getting vaccinated. Also factors such as the experience on site, the quality of services, the waiting times, information about the times and locations of those services, etc. Affordability, importantly, as well. And so we've used this as a basis for the development of tools for qualitative and quantitative data gathering efforts that would take place locally by programs or by other partners as well, to enable us to have this complete understanding of what these drivers are, both at a local setting in a way that they can be acted on to inform that local planning and the local design and evaluation of interventions, but then also endeavouring to bring a lot of this data together at a global level so that we're able to follow across these overall trends on key indicators over time as well. So it's important to note that these four drivers contribute to shaping uptake. And it's also important to note that this then informs the tailoring and targeting of different strategies on each of these different drivers or barriers. And the last important point here is that where we situate what people think and feel confidence, this is not always associated with a vaccination outcome. So people could report feeling that perhaps they're not so confident in vaccination. They might report having concerns about vaccine safety or not being fully convinced about the importance of vaccination. However, if we get these other areas right, a supportive social context and the systems and services that really easily enable those behaviours, that's where we can overcome and play with some of these different levers to ultimately design our programs to act holistically on these various ranges of drivers in ways that are context specific. So thinking now just specifically about what targets this shift from intentions and motivation into vaccination as an action. And we know that these interventions that directly shape behaviours, that build on intentions or shape behaviours in other ways through incentives or requirements, but importantly, the reminders, prompts, primes or nudges, we've seen from the evidence that these are often the most impactful in actually contributing to achieving vaccination outcomes. So this is really, a lot of this work is embedded across our guidance as well. So then coming to the range of interventions and programmatic activities that are necessary. So for COVID vaccines, and with the inputs of a range of global partners and regional colleagues as well. So with particular acknowledgement to UNICEF, CDC, Gavi, Gates, IFRC, the American Red Cross, many other partners who've contributed to our guidance in this space, we've mapped out these main areas of action. So not just the overall planning and coordination at a national level amongst all the key partners and stakeholders, we've highlighted the importance of routine gathering and use of this social behavioural and data, but then also these various areas of intervention. And you can see here how they then correspond to some of these areas in our behavioural social drivers framework. So those that act on service quality and the support to providers, community engagement and empowerment, and that work with advocates who can champion and promote vaccination, how we facilitate behaviours through these systems or structural interventions, policy related sometimes, and then importantly, the communications and anticipating, addressing misinformation, but really ensuring that there's a trusted information environment that helps to avoid any gaps in that respect as well. So going further into the communications space, because we know that obviously this is an epidemic right now, so-called, this a lot of information right now, not only about COVID vaccines, but COVID more broadly. And we're in a very complex and dynamic context, very changing, evolving situation with all these questions around the different vaccines, their effectiveness, their safety, the variants now, questions around boosters, what vaccines are allocated to what populations. It's such a complex, changing environment that how we communicate is absolutely critical. And here's just a few points that are also from a lot of evidence and best practice that we've seen around the world that really contributes to informing positive choices. So just the importance of communicating with transparency, clarity, simplicity, actionable wording, using language that's very relatable and also considers literacy levels of different target populations, making values explicit and bringing in the importance of what this means for eventually being able to get back to a normal or so-called normal life again, seeing family and friends, working normally again, maybe one day traveling if we can. And then also what it means about facilitating access in a broader way, working through many intermediaries who bridge into further communities. So through these trusted sources to really make sure that we're reaching all of the right audiences with quality, accurate information that meets their needs, and that we're doing this through the right people and partners as well. So it really means that we need to ensure that this communications environment is really well managed and that it's not just one way. We need places where people can engage for having their questions and concerns addressed as well. Most likely in the healthcare setting, as we know that health workers are often the most trusted source of information about a decision to vaccinate. But then when it comes down to having conversations at more a local level, whether this is applicable to that healthcare setting or even in other places, a workplace or just amongst peers, for example, we know that when people have these questions and concerns, a guiding communication style, not directive, a guiding, supportive style is the most appropriate. So starting by listening, asking these open-ended questions and acknowledging concerns, then being able to answer those questions, sharing further information where needed, referring people to other sources, and then, going further to explore and really fully understand what are those issues, but also on the other hand, what are the reasons why we do want to get vaccinated now? What will it mean for us individually, our families, our communities, following through with a recommendation based on the evidence. We know this is still the best thing to do. And if needed, finding ways to continue the conversation. So this is also at the heart of a lot of our tools and guidance. And we have a specific a guide on the WHO website, which goes through this structured approach to these conversations with those who might have questions or concerns on COVID vaccines. Now, in specific communities or settings, we know that hesitancy or under-vaccination is often clustered in specific populations. And so this needs a very targeted, tailored response that's data-driven and participatory. So working together with UNICEF, we've taken the human-centered design approach, plus also the tailoring immunizations approach, tailoring immunization program approach that came from the WHO Euro region with loads of expertise in over 20 countries in the last decade. And we've combined them into this participatory, context-specific, very user-friendly and data-driven approach to being able to look at specific communities and contexts where we know the reasons for under-vaccination are context-specific, and then going through this participatory, inclusive, equity-based and data-driven process to really understand what are the underlying issues, the root cause of those problems in this specific setting, and doing it in a way that generates buy-in and engagement and ownership for that problem-solving process. We've just been carrying out a series of workshops in a couple of regions with the Western Pacific and Southeast Asia, together with UNICEF, co-led, and really supporting use of this. And we've seen a lot of great creative new ideas emerge in this as well. Now, looking at the different reasons in our analysis that are emerging as the main reasons for under-vaccination. So here's just a rapid snapshot of what we're seeing from the African region around the main reasons why there's perhaps under-vaccination, and just zooming on a few of them here. So in this what people think and feel domain, a couple of things particularly emerging. The safety concerns and some of the difficulty in addressing those concerns, particularly around the AstraZeneca vaccines that have been suspended in some countries, but then restarted in certain populations, but are still being used in many other parts of the world. Myths and misunderstandings that also need to be addressed. But then we've seen the majority of issues really center around the practical issues where there's been supply constraints and difficulty in allocating and using that available supply effectively, gaps in service delivery for these new prioritized populations, or even other kinds of challenges in reaching these new population groups. And then also at the same time, the inability of programs in places to manage high demand, where they've struggled to manage crowds or that demand effectively to avoid an erosion of any future willingness to return. So we've also seen across this entire picture that there's been various funding gaps. These are now increasingly being addressed through Gavi support and other partners, but this has also been a contributor across the range of factors here at a very programmatic level. But what we ultimately know is that we really need to go local. Because these reasons for under-vaccination are so context specific, we need that local data that really can be gathered through very rapid surveys, a couple of focus groups, rapid research to really understand and engage, and then come in with the right kinds of co-design strategies as well. So just to start to wrap up, got a summary here of the various guidance from WHO and partners that is available. Here on the left-hand side, this is a multi-modular package of guidance around planning, budgeting, the data gathering, and then community engagement, misinformation management, health worker toolkits, tools for those health workers that need to be supported not only in their own acceptance, but their interactions with the populations that they serve, these conversation guides that I've already mentioned, and various tools and guidance then on the right-hand side here around communicating the science and the complexity of the vaccines, Q&As, and everything else, and further trainings that are also available on these various topics. So wrap it up there, but also happy to come back later and take any questions and further comments. But thank you very much again. Thank you. Bye-bye.
Thank you so much, Lisa. And I'm going to pass the floor to Neetu. But before, I want to clarify that I suspect I've given people the wrong instructions regarding how to submit questions, because I thought everybody had the option everyone available to them, but it seems that they don't. So if that's the case, please do use the chat and address the questions either to me or to all panelists. And I will keep an eye on the chat box and start collating those, and then we'll come back to those in the Q&A. So apologies for the confusion. So just to reiterate, you can either address them to me or to all panelists, and we will be able to see those. So over to you now, Neetu.
Thank you, and I'm just pulling up my slides to share. And also thanks to the World Bank and all attendees for this really great session. And I also, had the good fortune of working with Lisa for some time at the global level as well, and it's really great to see how far that guidance has come. So thanks to her as well for presenting. Can everyone see the slides? Okay, great. I'm going to put it in the slideshow, and it's actually a very good companion piece, because I'll be talking about mobilizing communities to increase demand for COVID-19 vaccines, the CDC vaccine confidence strategy. And this is really going to be a case study in what we have been doing for the last, many months on increasing confidence and demand for COVID-19 vaccines here. I have been the co-leader of the vaccine confidence team since December. So I'd like to start out with kind of a framing of when we are talking about vaccine confidence, we're really talking about trust. And vaccine confidence is the trust that patients, parents, or providers have in the vaccines that are recommended, the providers who administer the vaccines, as well as like a whole system of processes and policies that lead to development, licensure, manufacturing, recommendations. We have public ACIP meetings where these decisions are deliberated, and they're made public for a reason, to instill confidence and trust and transparency in the process. And so it's this trust that really underpins confidence. At this stage in the COVID-19 response, what we're really talking about is the movement from vaccine confidence to demand generation. So where we talk about building trust in the vaccine, the vaccinator, and the system. We also at this point are trying to mobilize individuals and communities to seek support and advocate for vaccines as being really vital. So excuse me. Okay, so what does that mean exactly? Demand generation to us looks like motivating people to get vaccinated by making vaccination the accessible, doable, and socially supported choice with on-the-ground social mobilization efforts. And when we are, and I think Lisa touched on this as well, it's both access, but also confidence and your feelings about the vaccine that are important. So here are kind of a series of headlines that are indicate what innovative things people are doing to sort of make a vaccination very appealing decision. So New York City offers walk-up vaccinations in public trusted spaces like their museums, Uber giving free rides to get vaccinated, the city of Detroit doing a door-to-door knocking campaign to reach people where they are, literally in their houses. And also other cities kind of toying with different types of incentives or attractive packages to make vaccination a socially supported choice. So these are things that we're tracking, and they're happening at a state and a jurisdiction level in the US. When we talk about building demand for vaccines, we've boiled it down to some what we consider to be keys for building demand. So you want to make vaccination accessible, sort of easy to get, make sure those sites are conveniently located, that the hours are convenient, that they meet people's needs, to make it beneficial, seen as beneficial, so that the health benefits outweigh the risk of getting COVID-19 or any perceived or real side effects from the vaccination. You want to tip that balance. Also making it convenient, making sure that everyone understands that these are free vaccines, that they're reducing even out-of-pocket costs related to transportation or those sort of other issues that can affect someone's vaccination behavior. Making it desirable, so appealing, normative, presented as a social default, or making sure you know that other people around you are getting vaccinated, as well as necessary. So this kind of goes into the territory of requirements and different things that that local systems are using to kind of make vaccination more attractive. This is some data by the Kaiser Family Foundation, which has been producing some really wonderful reports on a monthly basis about where we are with relative to vaccines. So we've been watching this. We also have a lot of CDC kind of data-driven systems that are telling us similar things, which is that over time, there have been there's been an increase in people who have gotten vaccinated and have sort of reached out. The other categories, we're seeing a diminishing number of people who say they're going to get it as soon as possible. Most of those folks have gotten vaccinated, and there's just a small percentage left who say they want to be vaccinated but haven't yet. And then the movable middle, which is that sort of wait and see category, that is also shrinking. So people are sort of moving into vaccinated status. But what's staying relatively stable is that sort of reluctant, or that only if required or definitely not category. That hasn't moved much over time. And so this kind of demonstrates, the benefits of directing efforts towards this movable middle, but some of the challenges in reaching those who are sort of entrenched against vaccines. This is the vaccination continuum that we feel helps us really understand vaccine behavior. We know that it's on a continuum. It's not categorical. It's not sort of static, that you can range from refusal to demand. But then there's this very important group in the middle, that wait and see group. And that's where we direct many of our efforts to trying to reach them with better information and strategies. And this is the measuring social behavioral drivers model that Lisa touched on, and it's something that we have also used quite a lot in our US-based work to capture some of the factors associated with vaccination behavior. And so I won't belabor the different categories, but this has been very helpful in thinking about not just what people think and feel about vaccination, which is where we've traditionally put a lot of emphasis in measuring and understanding vaccination, but also on your social norms, on motivation, as well as these really critical practical issues and access to vaccines. This is our Vaccinate with Confidence strategy that we have been that's been posted on our website since earlier this year, and that has been in use for many months now, that has been really directing our programmatic and policy efforts around vaccine confidence and demand. So there are three main buckets of activity. One is to build trust, to share clear, complete, and accurate messages about COVID-19 vaccines, and take visible actions to build trust in the vaccine, the vaccinator, and the system in coordination with a range of partners. We also empower healthcare personnel. We promote confidence among personnel in their decision to get vaccinated, as well as to recommend vaccination to their patients. And we engage communities and individuals in a sustainable, equitable, and inclusive way, using two-way communication to increase collaboration and sort of have these really important partnerships. And on our website, you can find the objectives and the sub-objectives of how we reach our goals. This is sort of a depiction of the ways that we support from a federal level the states and jurisdictions that are really implementing many of our programs and policies on vaccine confidence and demand. So we separate this into three main categories. One is direct support. So this can be deployments on a particular vaccine confidence and demand issue, a confidence consult system that has been a way for states and jurisdictions to reach back to federal partners to receive support on a particular challenge that they may be facing. We also have guidance. We've been doing vaccine confidence boot camps, which is a 2 to 3 hour deep dive into vaccine confidence and demand with interactive hands-on exercises, toolkits, which are posted on our website, as well as the rapid community assessment guide, which I'll talk about in greater detail in a moment. And we use data. Data is the cornerstone of what we try to do in terms of improving policy and programs. We build behavioral profiles of those who different intentions to vaccinate, as well as vaccination status, produce a state of vaccine confidence report, which I'll also talk about, as well as use a variety of quant and qual data collection tools to sort of underpin our understanding in this area. So this is our rapid community assessment guide, and it is posted on our website in case there's interested in understanding it more. But these are the objectives of using an RCA is to identify who it is that you're concerned about in a particular community who might be at risk for low vaccine uptake or actually demonstrating under vaccination. It is used to assess barriers as well as facilitators to COVID-19 vaccine uptake, to identify community leaders and other channels within a community that's very important to act through, to document lessons learned from one phase of the rollout to the next, because in this response, we do have the benefit of a staggered sort of rollout for different populations, and to identify, implement, and evaluate strategies. It's really that last point that's most critical, that this is a solution-oriented process to understand what we can do to increase vaccine uptake. The RCA process is built on principles of community-based participatory action research, to identify objectives, plan for the assessment, collect and analyze data, report your findings, and evaluate your efforts. And you're doing all of this in concert with state and local health departments. And we have various tools that are in this guide. So a learning template, key informant interviews and listening sessions, observations, and also traditional social media monitoring. So these are findings. This is a very high level recap of one that we did in the state of Georgia here actually that was in April. And we went to Dougherty County and Bacon County. So we're two different counties with two different sort of demographics and reasons for under vaccination. We did mostly key informant interviews and listening sessions, observations, street intercept surveys, which is sort of talking to people and local people and local businesses, driving through community communities. And we found, sort of on a high level that at this point in the response, there was really quite good supply, but that there were a lot of circulating rumors and myths around vaccine development and side effects, many challenges around communication, and overall distrust in the health system. We also uncovered quite a lot of access issues, even though the supply was improving. Bacon County, similar, but this one had more emphasis on farm workers and different population, more rural population as compared to Doherty County. So we do debriefings and produce reports and disseminate findings to the state and local health department. Underpinning what we do around the results of the rapid community assessment is an emphasis on trusted messengers. So to build trust and vaccine confidence among patients we know that it's critical to high vaccine uptake, and trusted messengers are really a cornerstone in this process. Trusted messengers effectively deliver messages and strategies. They can validate the credibility of information. They can be vital in sort of addressing mis and disinformation, and they can create feedback loops for addressing questions and concerns that give us an indication of what the community level concerns are and how we might address them by improving our systems. So to transition a bit into the infodemic, we know that in this stage of sort of a lot of information out there on COVID-19 vaccines, credible, authoritative voices must compete against misinformation that is deliberately packaged to provoke strong emotion. And this is sort of a major issue at every level. We're seeing this occur locally at the state level, and also impact what we're doing at a federal level. So what we've done on our team is created a behavioral insights unit that produces a state of vaccine confidence insight report every 2 weeks. So our insights report is a real-time rapid assessment of public sentiment around COVID-19 vaccination. We analyze public perception and opinions, identify information gaps and voids and any message penetration issues we might be having. And we also are able to detect mis and disinformation as it emerges due to the rhythm of the report and the rhythm of the data collection period. We utilize a mixed deductive and inductive approach, kind of drawing on principles of qualitative data analysis and coding and sort of reporting. And we summarize themes that include not just the particular information, but also ways to act for all of the entities at various levels, at the federal, at the state and jurisdiction, with our partners and more. And so this is an example of one of the themes, which are women are experiencing unique and increased side effects after vaccination, and then also ways to take action. And these reports are actually now posted on our website and publicly available. You can review. We're now on our 10th report, so you can review all of the previous reports as well. This behavioral insights unit has been really critical for us to get real-time understanding of how information is traveling across these different levels, and also to inform the action our team takes. So the primary purpose is to inform sort of how we're communicating from our level, and also the guidance that we're developing and disseminating from the CDC's vaccine task force. That we adapt methods to perform rapid assessments and deep dives into specific issues and populations. So when we have a concern or a question about a specific issue, we can adapt and create a special report for that, for instance, around adolescent vaccination. And this is an example of how we've used behavioral insights to actually partner with trusted messengers. So hashtag This Is Our Shot is a campaign of grassroots healthcare workers, more than 25,000 healthcare workers and vaccine advocates in California. And they have been receiving our State of Vaccine Confidence report, and so they will sometimes direct their tweets or messages in response to the themes that we're picking up that kind of represent public sentiment about a particular topic. So for instance, vaccines are working, a very small percentage of vaccinated people have caught COVID-19 in response to concerns about breakthrough infections. So that is sort of a big tour of the types of programs and policies and initiatives that we have developed over the past months to increase confidence, demand, and uptake of COVID-19 vaccines. And similar to Lisa, I'm happy to take any questions during the Q&A period. Thank you.
Thank you so much. We are going to go to Renas for the last presentation. And I just want to remind everybody that you can submit your questions and comments using the all panelist option. And I just see one that came, so it seems that people are warming up. We'll open up the discussion at around 10 after Renos. Renos, over to you.
Thank you, Carol, and thank you, Lisa. And thank you. So I'm going to share some of our early insights that we're doing in some of our efforts to collect some of the information across the world, exactly what Lisa and Nitu has been discussing. So I'll give you kind of our tour of first. So as David, said, we have vaccines, and here's some kind of the early stuff. There's about 400 shots per second. And one interesting piece of data is there's an estimate by the end of the year, there's going to be 22 billion doses available, which means pretty much everybody in the world should have access to a full vaccination, and a vast majority with one more booster. But as we'll discuss later, there's high inequality in access in these vaccines right now, and one of the issues is trying to understand how to address that. Vaccines do work. We see kind of some of the leading countries in terms of kind of increasing the dose. You see this nice correlation and in decreasing rates of new cases and deaths in some cases. But as you see here, regionally, we're still far behind, reaching kind of the 70% of where we kind of the medical community suggests it's where herd immunity comes in. And you actually see it within the countries. Even the leading countries that you see here are much far from this kind of dotted line, which is kind of the reaching herd immunity. So there's a lot to, there's still a lot to do. And one of the issues, kind of, I think you can see from this graph, is countries increase their dosage. You see this decreasing kind of a take up. You've seen it in most countries. So, Lisa Nitu alluded to that, really great conceptual framework about how to think behaviorally. And in some ways, kind of this speaks to kind of us understanding kind of the three buckets of what they talked about, to how do you help people understand that, both the virus risk as well as the vaccination benefits. How do you make sure people have confidence and they trust the system and vaccines, and how do you make it easy? So we wanted to also understand in the context of kind of the World Bank working with kind of the work that we do around the world. So we decided to start kind of to one of the tools to use is to collect data through social media. Why? Well, half of the world is connected already on the internet, so that gives us kind of a head starting point. And we try to do three things really. So the first one is really to do these diagnostics to understand exactly what we heard before. What are the people's feelings, their concerns, what are their intentions, and how can you try to use that to distinguish across the different types of people that exist in the population and their attitudes towards vaccination. The second thing is we wanted to push this a little bit further, and we wanted to actually really test, kind of a first set of messaging that could be done, and try to understand how these messages can affect, different types of people. Because as we've heard before, vaccination decision, it's an individual decision. It's not an average decision. So we need to be able to target specific, communication to the right people at the right time. And the third thing we are trying to do right now is we learn these things, and we're working with our health colleagues and countries, ministries of health, and all the local actors in countries. We're also trying to build and bring our behavior hats and provide kind of technical assistance to the local country level communication efforts and beyond. And there we're also trying to get much beyond communications. So what do we do in social media? Well, we created a chatbot where we use it to collect data at each country we use a sampling to allow us to do some post sample estimates based on national population. We can do this in about 2 weeks in a given country, and as we do this, we reach a couple of million people in a given country. We aim for about 5,000 people response to allow us to do some subgroup analysis to understand further kind of the typologies of the attitudes, and because we can take advantage of social media, we can keep costs quite low. To date, we have collected around 70,000 surveys in 8 countries. We have 22 more underway, and we're really trying to scale this around the world. Kind of the user experience, somebody sees an ad in their feed in Facebook, they click, and then they go to the chatbot where they spend about 7 to 10 minutes to respond to these questions. So what are we learning? So kind of a high level kind of insights. So I hid the countries. So these are country statistics, but since we haven't actually presented some of this, I'm kind of hiding it. But the point here is that intentions do vary, and it's also going to vary depending on where vaccination is at the time. Most of the places we started actually vaccination hadn't even started yet, and it's really at the early stages. But just to kind of and one interesting thing that also in a way speaks to Nitu's point earlier is that when in a place like this where vaccinations haven't really started, you're going to find a really big unsure kind of uncertain group. And as she was saying, you're going to always have kind of this very kind of a stable group of no's, kind of the anti-vax kind of a space. But then this middle ground is where you have all the very rational, logical people who just want to understand more about vaccines. It's quite thick. But here's a case where vaccination actually among respondents was quite high, about 45% of the sample was vaccinated. And here you can see that actually we have a much more tighter kind of a group of uncertain people, and equally on the no. So this speaks a little bit about dynamic monitoring and the need to actually keep track of these things, as Nitu and Lisa were saying. Doing this in frequent intervals is going to be important for us to kind of guide policy and communication. As again, Nitu and Lisa said, this is about communities and understanding kind of people. And again, we see a lot of variation across regions, across ages, and especially this insight that so far seems to be consistent in most settings where women tend to be actually less likely or more less likely to be willing to take the vaccine, kind of at least in where we measure it. But I guess the second kind of really big insight is that what really actually explains some of the intentions are behavioral questions. So this is so for example, this is an insight around the correlation between kind of local social norms. So what we find is that the take-up attitudes of somebody really mirrors what they think people around them are doing or believing. And you can see kind of as you move from the people who say no and sure yes, you see this really kind of strong, kind of relationship between these two relations. So we also have done this with other behavioral variables about trust, about kind of a preventative measure people are doing early, previous vaccination, that we define these kind of more behavioral variables to provide a big guidance as to why are people, kind of doing or believing what they do. Then what we're trying to understand is, what do people are worried about? And again, this is also useful because it starts kind of helping us understand kind of typologies. So one group that comes up is, people, and, they want to understand more about vaccines. So we're asking, what are your concerns? And as you see, most of the people really, and accurately, correctly care about long-term side effects. But then there's another group which we're putting more into kind of the higher resistance, And again, you can see this kind of a group emerging around kind of a pure anti-vax kind of feelings and trust kind of considerations. And then there's this third group that's also interesting, because this is a group that the best we could label, we would call it kind of uninformed, in the sense that these people that either tried it, or for some reason they don't have concerns, or they don't think vaccines would work. So we feel this is a group that could get some support by more kind of a more information, more kind of a technical information, if you want, about the vaccine. Both Lisa and Nidu talked about messengers, and again, we asked, who do you trust? And a couple of things pop out. People do trust the medical community. That's great. As you see, as you move to the more resistant groups, these numbers get a bit lower. But the second most important thing, again, most people, especially if you get much more to the kind of the resistant groups, do trust much more family and closer, kind of connections. So again, it brings back to this question of design. How can we leverage, family? How do you help, family members or local communities to share and become, champions of positive, solid messaging around that. And one worrisome piece of information that these surveys are telling us is that healthcares are humans, in the sense that we don't really find anything more exciting in terms of their attitudes towards the vaccines. So they have equally amounts of hesitancy and equal amounts of uncertainty, and they're doing a little bit better in terms of intention. So we find this consistently across countries. So this means that as people trust, people trust health workers for messaging, but themselves have uncertainties and are skeptical. So definitely what governments can do is to really boost the training and the information and everything that we can do to support health workers, both because they're at the front lines and their bandwidth and constraining and they're doing all their efforts, but also because they also need to kind of process this information. And I think Nidu gave a really nice example of some of this reporting that is happening in California, for example. So we had this interesting question about, well, why would you get a vaccine? What do you think would be? And again, as you move to the more hesitant groups, you find more people that say, well, there's no really good benefit. But again, if we think about communications, we do find that, kind of this idea of coming back to normality is coming up as an important, lever and motivating factor, at least for the kind of the most unsure, group. And then there's this other angle about protection, which is both protecting myself, but also protecting others. So again, this gives us some insights about how to think about, kind of social, framing that speaks to protection, speaks to protecting others, etc. So what we do then, so this is kind of the diagnosis. So what we do then with phase, kind of the second exercise, is we integrated kind of a randomized trial, if you want. And based on this kind of early information, you can, we can create, kind of these groups. You could imagine others, but, for this, so far we start kind of grouping the data in each country across, kind of these, 4 or 5 groups. And we want to see if messages that go out, to different groups have different effects. Again, what's nice with this data, we can understand a little bit more, what is the determinants of each group, what are the correlates, and we can use that to also help us with targeting. So here's an example. So again, these are causal effects of different framings, and as you can see, on average, so this is I think I can say this is in Lebanon because we did present it. But if you change the framing and in addition to asking people, do you intend to take the vaccine when it's available, if on top of it you tell them that, by the way, experts are saying these are safe and effective, you get a 20% increase in the people that are saying they were willing to take the vaccine. And if you go all the way to the right, that increases by 60%. So peak effects, again, a lot of it is coming in this space from this uncertain group, which requires a little bit more solid information. But you can see how one sentence can actually have a powerful 60% increase. And connecting experts and religious leaders in this setting actually does a really nice effect. Similarly, if we target messages to health workers, we do find in this case, again, that what they want, health workers, really a solid message from, or a message that kind of gives them support that local health experts and international experts are saying the vaccine is effective. And again, this increases health workers' intention by 44%. And so what we've done with this data is then we try to kind of break down this kind of typology and understand, which message is going to get for which people. And again, this is the last example to say that if you send a message to people who care about safety, a message that talks about safety, you have really huge payoffs, almost, more than doubling the effects of the intention to take the vaccine. So this is just to show you kind of the power of. So these are kind of my last kind of couple of slides. So this is, you're not supposed to understand this other than kind of qualitatively. Yellow means the messages worked for a subgroup. So each of the words are kind of characteristic. So the way to understand this table is on the top, as you go from the top to bottom, these are the correlates, the proxies of those groups that you see. So as you move down, those variables are basically related to proxies that capture the description of people with safety concerns, people that we kind of define as uninformed, or people not trusting and vaccine resistant. So if you go from the top to down, you're actually trying to reach, in a way, more complex, more deeper kind of a resistance. And as you go from the left to right, we're playing with different framings. And as you see, while we do find some positive effects in switching, kind of increasing the rates of intention, you definitely, the second and the third variants of framings here, connecting both, kind of a recommendation, about the vaccines, plus kind of invoking messengers, do seem to have a larger effect, especially when you bring religious leaders in this setting, but also in the last case of religious leaders, you start actually having effect on some of the much more complex groups at the bottom. And this is another country where we actually introduced a different set of framings, and we kind of updated some of the framings to include things like social norms, not only telling people, kind of about that others are doing it, but others are doing it kind of in increasing terms. And again, you find something similar, that as we move from the top to bottom, we find in kind of a, much, some of the effects are less, but, in this context, the last column, where it's called efficacy and pro-social. So these are messages that both spoke about the effectiveness of the vaccine, but also the fact that you would be actually protecting people as you do it, actually seem to work really well for the top two groups, those with safety concerns and uninformed, but also potentially with some of the more resistant groups. But you can also see on the first column called experts, that didn't work. So what's nice about this experimenting, we're both understanding what works in general, what works for specific groups, and what can work in different settings. So I think this is my last slide, just to say it's important to think beyond communication, and I think Nitu and Lisa alluded to that. I'm putting Mike Pence here partly because he's a good role model for potentially kind of a group that correlates with anti-vax. So how do you leverage some of these groups across the world in different settings locally? I think what we can do with social media is also make things more interactive. So this is a really cool kind of a game in a way. So gamifying a way of people to both learn about the vaccine and also understand about things like misinformation. You need to learn, talk to us about some, innovative ways. Kind of DC just announced that everybody gets free groceries if they win the lottery and after getting vaccinated. But this is kind of in different versions across the world. And then the last point here is that, can we make it easy through social media? kind of not banning vaccine together. Back to you, Karen. Thanks.
Thank you, Reno, so much, and thanks also to Lisa and Nitu for their presentations. I am keeping an eye out on the chat. We have a couple of questions already that are coming out there. So let's start the conversation, and I'll continue to monitor that. So Sifa, I'm gonna start with you so that you become a part of the conversation. And I'm gonna start with a couple of questions to you and Renas on how do we actually interpret this data that is coming out of social media? What are some of the caveats or things that we may want to keep in mind? And I wanted to start with you and maybe asking you to reflect a little bit on whether there are any sort of differences between women and men when we talk about hesitancy. It seems that some of the results that we see do suggest that that's the case. And if that's true, are those sort of specific to a particular country? What's your sense, or is this a more generalized phenomenon? And what could explain that, and what could be done about it? So bring in the gender lens, if you want, to this conversation, and what should we think about? Over to you.
So Carolina, I did hear correctly that you mentioned my name, right?
Yes.
Good. Okay, so I think I will start with the last one you just mentioned in regards to the difference between the genders. You're totally correct that we do see that the behavioral insights data that we have gathered, that we do see a difference between men and women, that it seems that women are a bit more hesitant in regards to vaccine uptake compared with men. And I think so that data has been gathered as a quantitative data, so that's part of a survey process. I think when we get such a data, I think of course it's important, and I think that's what we do, and that's what's been mentioned by all the presenters this afternoon, or in your regards this morning, is that you really have to be able to target your intervention based on the specific needs. So when we see data saying that it seems that women are more hesitant than men, then it's actually important to dig in and get an insight into then what is the barrier for the women before we draw any conclusions. So with that, I want to say that I think that raises a bit of a red flag and some concern that needs to be explored further, and especially if you're going to give a recommendation at a country level. And then you really need to understand that context, that cultural context, to be able to support them with tailored intervention that fit their needs. The reason I'm saying so, if I think in general, we know that, that there is a difference between men and women regarding health topic and issues that can also be a bit of an explanation and reflection in this regards, that men in general are not, necessarily that keen on, replying questions. Maybe they are not the one that, go to, a doctor and a healthcare facility. And so I don't think that necessarily it means that there are a huge gender difference. And I think if you then, decide to zoom in and only create intervention that is targeting women, you really have to be careful, because you end up leaving out a very important target group, which is men also. So it's just to say that I think it's important that when we have such results, of course, we need to take it serious. We need to look into it, and we need to understand what's the barriers and enablers behind it. But we cannot forget that men is also an important target group in this regards. So I think that was a bit of reflection in that regard. So in regards to the social media one, I think it would be great if you could maybe just repeat. And again, maybe I'm not the right person to answer the social media questions. I'm happy to give it a go, but I'm sure that other experts around this panel that are more, how to say, keen on answering that questions. So back to you, Caroline.
Thank you. No, you did answer my question. I don't know, maybe something got lost in the communication.
Okay.
So you're good. Perfect. Thanks. Renos, maybe let me come to you and continue on this sort of first set of questions on, who do we really have data for, or we don't, and how should we then interpret this information? And I want to pick up on something that you put up at the end of your presentation, where you talked about coverage of social media, right? And the fact that not everybody has access to social media. So that's particularly pertinent, right, for the work that we do at the World Bank, where we engage with a lot of countries where that's probably the case. So how do we think about that? Do we just assume that the people that we don't cover think and feel exactly like the groups that we cover? You know, what are the implications of this uneven coverage? You know, so how should we think a little bit about that? And actually, I want to build on that and ask, you know, piggyback on, you know, a question that we got from the chat that says, well, if you think about fragile environments, right, where this is probably even more acute, you know, do we have any good examples of using leaders, community leaders or religious leaders to overcome some of the challenges that we may have in terms of, you know, lack of information and others? Over to you.
Thanks. Yeah. So I guess three things on that. One, so the data we collect, you know, is not national representative. We can do lots of statistical tricks to, you know, to kind of create it kind of in the best image of a country. But we know that, you know, two things, you know, not everybody's on social media, even though some of the early countries have 60–70% of the population does have access to, you know, Facebook account, etc. But still, we know between, you know, who sees, you know, an ad, who clicks, and who finishes a survey, there's a lot of things that happens. What we were interested in this survey, and I think what's really useful in terms of a clean insight, is that, you know, given the population we care about effective communication. So to the extent that, you know, these typologies that we create are generalizable to some extent, I think, you know, we do want to have clean insights from the experiments we're doing on the messaging. Having said that, one of the next things we're actually trying to actively do is validation. So we have in the poverty team, you know, we have there's another project collecting country-level data on phones, using phone surveys, and those are designed to be national representative. Given that setup, they do not allow you to go to kind of this subgroup analysis as our samples does. But what we try to do is to have a shared, you know, kind of a harmonized set of, you know, questions that we can anchor. And what we're developing now is kind of an approach to do validation and understand both similarities and differences, and to what extent, you know, we can actually, you know, how exactly what you said, how to interpret that. In terms of how to reach other populations beyond social media, again, it is coming back to the question of how we can collect data. In some cases, it may be through phones. We're also exploring with other platforms like WhatsApp that is working through phones, and that has definitely much higher accessibility by kind of the more vulnerable populations that, you know, kind of, you know, we would like to reach. So that would be another complementary approach. But ultimately, it's clear that there's going to be groups that are really, really possible to reach, you know, with kind of a, you know, high-end technological solutions. And I think there, you know, some of these ideas that I think popped up earlier about using, in a way, you know, kind of a local institutions, you know, community leaders, religious leaders, to both kind of share message, but even think about collecting, you know, some sort of data, even if it's qualitative. I think it's going to come important. I think on your last point on the leaders, I think there's a lot of different examples of having kind of a leader, not just religious leaders, and how that influences. I mean, there was, I'm forgetting the country now, I think it was Iraq actually, a very well-known religious leader did kind of come and make a strong statement, and there's some, you know, kind of at least anecdotally positive insights about helping kind of shape kind of the opinions. And then at the high level, there is some recent work that Abhijit Banerjee, who is a Nobel laureate, who sent basically to, I forget how many million people in India, a 2-minute YouTube video through SMS. And that also, they managed to evaluate kind of the really high impact of a 2-minute video from an influencer who is kind of credible with, you know, with that population about preventive behaviors.
Thank you, Renos. And I see that Abby has posted a link on the chat with more information on the Iraq example that Renos just alluded to. So check that out for more details. We're going to change gears a little bit. And Lisa, I'm going to come to you to start talking about, what can governments do? What can actors like at the institutions we work for do? And in all three presentations, I think you all alluded to the important role that trusted messengers, that health workers can play, right, in addressing hesitancy. So I was wondering if you could elaborate a bit more in terms of what can policymakers do, right, to leverage, trusted messengers in general, but also to address this issue that Renos raised in terms of hesitancy being high, even among health workers who are trusted messengers, right? So, so how can we sort of leverage this group generally, and more specifically, what are some specific actions that we could target to health workers to really make sure that they are helping us address hesitancy overall? Over to you, Lisa.
Yeah, thank you very much, Carolina, for the question. And there's a few different parts to that, but I'll break it down just by firstly talking about what can institutions do to promote trust and be trusted. And I think that trust is about being honest, transparent, relatable, and really being empathetic. And I think in some countries, we've got examples of countries that have done this well and others less well, where there are leaders from institutions who have demonstrated their caring and respect and a kind of kindness in the way that they've delivered information and spoken about COVID vaccines. And this even relates more broadly to the way in which they're perceived to have managed the COVID pandemic response more broadly. That if they're not perceived to have managed that well, then that also has a spillover to vaccination. So there are many elements to what institutions can do to foster trust. And in addition to what I've said, I would also just add the partnerships with science, standing side by side with those trusted experts, the scientists who are kind of, to demonstrate that there's that collaboration and partnership, and the actions being taken are really informed by science and the evidence. So I think that's really important to begin with. And in a way, as Renos was saying, that, using the gain frame for some of this messaging as well, that we've seen so much of a saturation of fear and worry and anxiety with, again, the pandemic response more broadly before we even talk about vaccines, right? So I think that as part of institutions demonstrating trust, it's also through this messaging around vaccination, it's not only the speaker, their platform, the message, etc., but in the delivery, putting a focus on really what can be gained by the use of vaccines, and showing that, this is a step, it's one step of many of all these other preventive behaviors we know we need right now, but that it really is this step towards us getting back to some kind of normal life, and those interactions in families, communities, a social life, a travel freedom, etc., that framing it and showing what that means, I think is really important. And then just to quickly touch on your point then about health workers, and we know that trusted health workers are probably, in many settings, the most trusted reference for information or to guide a decision to accept vaccination. And health workers themselves play such a central dual role here as these critical frontline workers. They're our heroes, and we really need to be working together with them. And, maybe to many, particularly in the scientific medical domain, it's surprising that a health worker might not want to automatically accept vaccination. So we need to respond to that, again, with this empathy and really bring them along as partners and work together with health workers and, consult with them and co-design the necessary strategies with them. So health workers need to be these partners, not just recipients of information or of strategies or interventions. And they have so much expertise. They know their communities. They know how to reach their communities, and we need to be drawing on that expertise and making sure that they feel like they've been part of this process. And that then brings them on board, not only in receiving vaccination, but, you know, fostering their trust in the system, you know, the institutions, the authorities, but then also, of course, what that means for the spillover to the populations they serve. So that's just a starting point. A lot of this is reflected in the guidance that we make available. And, you know, ultimately it does come down to these local strategies as well. So it's often really hard to make these, you know, generalizations about a one-size-fits-all approach. It's really context specific, and we need these multi-pronged strategies, whether it's about trust, the role of health workers, etc. So I think that also just needs to come through pretty strongly as well. Thank you very much.
Thank you, Lisa. Maybe continuing on this vein of sort of policy actions and you know, how can we act on the information that that we get from social media and others need to, let me come to you. And there were a couple of questions on the chat saying, well, but what has worked? You know, what do we know works and doesn't? So I was wondering if you could tell us about maybe something you've seen that you think has been particularly powerful, you know, your sort of favorite intervention in this space that you think has made a difference, or if you have broader reflections on, you know, what works, at least that we know of at the moment. Over to you.
Yeah, there have been some great insights I've been hearing, even in this Q&A session, on, you know, the role of finding who these champions are, the trusted messengers, the healthcare providers, empowering, you know, different strategies for different types of messengers. One of the kind of interventions that we've seen organically emerge are these sort of patient navigator systems that have worked well for other disease areas like HIV, care and treatment, and other kind of areas. And what is wonderful about these systems is that they can be managed by different types of trusted messengers, including peers to peers. And they explicitly call out this linkage to care or access issue, in addition to kind of the other confidence and demand strategies that we might advocate. So providing the right and accurate and clear information about vaccination, but also being able to help somebody navigate systems that are complex and try to find them vaccinations that will kind of match what they need. I mean, I think earlier on, we saw these organically come up with younger people helping older people navigate, you know, complex online systems, especially when the supply was very constrained in the US and it was difficult to find a pharmacy. Appointments would disappear rapidly, and so even though older folks were, or older population was prioritized, they were having a harder time navigating the digital environment. So we saw young people step up to the plate and help their family members or friends or people in their neighbors, people in their community to navigate these online systems. And then, you know, when supply became less of an issue, it became, how do we get people to the facilities that they need to go to? So how do we get them to the mass vaccination sites or the providers or the pharmacies that, you know, have vaccinations? So that I thought was really a great example of sort of a call to action provided, you know, right next to an opportunity to be vaccinated. And we even have different kind of professional organizations and professions interested in using that approach as well, like social workers, like these critical roles. When we think of healthcare providers, we often think of medical providers, you know, doctors or nurses, but there are this whole cast of supported sort of professions that can help us also instill confidence and demand for vaccines, especially in disproportionately affected communities, but also link them to services. And I think those programs that have come out of communities that are very holistic, that are tapping into multiple dimensions of vaccination behavior, that's been really great to see, because that's really arisen organically from, say, the experiences that community-based organizations have had serving particular populations. So those are programs I'd like to see scaled up, especially as we're thinking about LMIC and the global environment. How do those programs, you know, what do they look like there?
Thank you so much. Steve, maybe let me come back to you with with another question that also picks up a little bit on what we are hearing on the chat. And it's sort of saying, okay, we are talking about sort of social media and information, and we are very focused on how we use that for communication, right? Understanding these behaviors and how we can nudge behavior. But there are other areas, right, in the vaccine distribution process where behavioral insights could also be important, where we could bring that lens to have more effective, if you want, rollout of vaccines. So I wondered if you can share thoughts on, beyond communications, where can this behavioral lens be useful in the current context around vaccination? Over to you.
Yeah, thank you so much, Carolina. So I think, first of all, I have to acknowledge this entire setup, and I also have to say that the presenters has been extremely insightful for me as well. So thank you so much. And I think all the important things has actually been mentioned. But if I can maybe reflect a little upon the importance of also involving the technical area when we talk about a new vaccine introduction or vaccine introduction in general. It's very important to see the broader picture. We cannot just go ahead and develop communication messages and social media messages, and that's already been mentioned that we need to tailor it. But I think it's very, very important that when we introduce a new vaccine, we have a huge setup. We have a national immunization program in each country. And the way the vaccine is actually introduced or offered to the population is something that we need to always look into. And that has to be part of how we then shape the interventions. So it's extremely important that, when we do work with the countries and try to come up with tailored interventions, that we also have an idea of how the introduction plan has been agreed on, basically. I think I can just give a concrete example. I just had a call with a country within our region, and they have issues with the AstraZeneca vaccine. And I think that's something that we're all aware of, that there's been a lot of misinformation about the AstraZeneca vaccine. And they, of course, asking for request in this regards. So of course, what we do, we need to understand a bit. So how have the vaccine been introduced so far? How have they agreed on or decided to basically offer the vaccine to the population? So what we just learned was that they have actually offered several vaccines at once, and they have not specifically prioritized target groups and or vaccinations, meaning that it's been free of choice. So the population can sign up for a certain vaccine, and nothing has been done to push for some of them. So now they're having an issue that they have way too many AstraZeneca vaccines compared to the other one, because of course there's this lemming effect of population. If you feel that there's one vaccine that is more important than the other, then there's a push to it. On the other hand, we realized that there's a certain vaccine that was offered for the healthcare workers, which is not the AstraZeneca vaccine. And as been mentioned by Lisa, by Nedo, and all the other presenters, we know that healthcare workers do have a major impact and influence on the general population in regards to vaccination uptake and vaccination decision-making in itself. So imagine you have a huge and important population group that have not received the AstraZeneca vaccine, meaning that they most likely will not recommend that for the patients as well. So you can see here, so if you decide from a programmatic perspective to take a decision, then that have an influence on the uptake, as we go. So it's very important that you do understand, those decision-making processes to be able to support with the most feasible and relevant interventions. So yeah, it's very important that you also seek insights on all the decision-making processes that have been taken in regard to the deployment plan of the vaccine, and not only on specific target group and or media and or social media messages and so on and so forth.
Thank you. And we really have a couple of minutes left, but I want to come to the last question that was posed on the chat. And maybe, Renos, let me ask you to very briefly address this. And basically the question is, you know, what do we know about the correlation between intention, right, which is what we are probing on, right, on social media, asking people what they think they will do, and actual behavior? You know, do we know that one leads to the other? Because that's important, obviously, in terms of how we use this data and interpret it. So, Renos, I don't know if you guys have any experience on this from your work. So I'm going to start with you very briefly, and then, you know, and then we'll probably close after that.
Sure. So we have two things to say. One, from the data, we do ask about people's previous vaccination experiences, both for themselves or their kids. And again, just like other kind of behavior variables come out very highly correlated. So they do predict in a way, you know, kind of given your prior experience, you know, it's highly correlated with your intention to get vaccinated. You know, given where we are, what we're doing to learn kind of the actual vaccination, you know, COVID vaccination behavior in a few countries where the ministries of health are okay with it, what we are trying to do is to link the survey to the registration site when there exists one kind of online vaccine registration for that country. And we're trying to see if we can track people who go through kind of our survey into the registration site to see if they can follow through, if we can actually track at least in some high level, you know, to what extent both actually access the site and maybe potentially we can do it in a, you know, kind of a ethically correct way, anonymously, etc. We can actually get some comparisons of actual vaccination rates. So that's kind of on the to-do list.
Thank you very much, and thanks again to all our panelists and participants. It's clear that, you know, communication is only a part of the story, but I think we are walking away from this discussion with an understanding that it is a very important part of the story, and that communication needs to be tailored to the specific groups we are trying to reach, because as we've seen, beliefs and behaviors do vary significantly across different groups of the population. And then finally, I think a very clear call from all our panelists to leverage, you know, trusted messengers, including in the health sector, but not exclusively in the health sector, and how powerful that can be in again, moving certain groups that are at the moment hesitant into the vaccine space. So thank you so much, everybody, for a very rich discussion, and have a good rest of your day.